All right.
And Shannon, if you go to display settings at the top,
Yep.
and then swap presenter, it should work.
There we go. Is that good?
Perfect.
Okay, thank you.
Thank you. So hi, everybody. My name is Veronica Gillispie-Bell. I am an OB/GYN here in New Orleans. I practice at Ochsner Health. And I'm also the medical director of the Louisiana Perinatal Quality Collaborative and the Pregnancy Associated Mortality Review. I'm so glad to be here with you all today. Yes, Zoom gets to be a little bit tiring sitting on here, but it's a benefit because it's allowing me to be able to come and present to you in Virginia all the way from New Orleans, Louisiana. Today I'm going to be talking about respectful maternity care. I know this is something that, that y'all are embarking on and have an initiative around. And I'm going to talk about what role do each of us play in respectful maternity care. And so I have no financial disclosures related to the content of today's lecture. So I'm going to go through first the history of respectful maternity care. Where did this come from? Talk about some of the components of respectful maternity care. Talk about why it's important. I think we have some moral reasons why we understand why it's important, but talk about some other aspects. And then identify obstacles as well as practices to achieve respectful care. So let's spend a little time going through the history. I've been in practice now for 12 years. Respectful care is not something that I remember being taught in medical school. Probably you don't remember that as well. For nurses, I don't think that's something that we've ever talked about. And then all of a sudden, we started hearing about this catchphrase, respectful care. So where did it come from? So in the 1990s, in Latin America, actually, there was a childbirth activism movement, and it was really around not medicalizing childbirth and allowing women to be able to have vaginal births without the interventions of C-sections unless necessary, and other ways that we medicalize what is meant to be a natural process. In November 2000, the International Conference on the Humanization of Childbirth came around, where they started talking about what are the facts, the charters, what are the things that we need to say as an institution that support respectful maternity care. And in 2007, Venezuela developed a formal definition of obstetric violence. And this was also around, around the fact that women, as well as their newborns, deserve respectful care. And in 2010, Harvard case study was done on respectful maternity care awareness rising. And then the information from that case study was used to come up with the charter around respectful care. And next thing. And so this is through the White Ribbon Alliance, and we're going to review this on the next slide. And they created the respectful maternity care, the universal rights of childbearing women, based on what came out of that Harvard case study about respectful care. And then in 2015, there was a systematic review that updated that framework for disrespect and abuse. And then in 2016, the WHO released guidelines for improving quality of care for mothers and newborns around respectful care. So just to tell you a little bit about the history. Now, looking at that charter from the White Ribbon Alliance on the next slide, what it really boils down to, and the main point of the charter, is that respectful maternity care is founded in universal rights, and these are human rights. So rights that women and newborns have as humans. Next slide. And so to go through that more specifically, this means freedom from harm and ill treatment. This means information, informed consent, respect for women for their choices of preference, around their companion during maternity care, refusal of medical procedures, understanding that everyone has the right to privacy and confidentiality, dignity and respect from the time birth happens, and not just thinking about moms, but babies. When they're born, their human right should be to have dignity and respect, equitable care, as well as access to quality health care, liberty and autonomy, having children not being taken away from their parents and guardians, and then identity and nationality, and then the final thing being nutrition and clean water. So when you see some of the parts of the charter, especially around nutrition and clean water, identity and nationality, you can appreciate that some of the needs of the charter are not necessarily related to what we see in the US. So again, this charter came largely out of work from around the world, and that's why the World Health Organization is involved. So in a lot of third world countries. But the thing I would say is, are the women that are in the US still deserve the same aspects of respectful maternity care? And if we go to the next slide, if you think this does not apply to women in the US, think about all women in the US and all women that are giving birth. So this is a story out of Florida from February of this year. So not from 1980 or 1970, from this year. An inmate gave birth alone in jail without any type of care. She was shackled at the time, and though she screamed saying she was in labor, nobody gave her any attention. And so what you see right now is a picture. Her name is Tammy Jackson, and so lawmakers wanted to pass an act in Florida to ensure that that didn't happen again. I would like to tell you that is the only story of a woman be giving birth in a jail alone, but that would be a false lie if I told you that. This also has happened in Texas. The baby died 10 days after birth. Nobody even realized, because she was alone, that she had given birth. This happened in Denver, and there's been legislation passed around that. So all of our women in America deserve to have a dignified birth. And these are just some examples of some of the women that are not always given that right, what is supposed to be a human right. And again, when we're thinking about respectful care, mainly women want to be heard. They want their voice to be heard. You saw in the charter that part of it is being able to have informed consent and shared decision-making about your care. And so these are two stories of women that were in the media about not having their voice heard. Again, we talked about the women that were in jail, and so you think about them as a subset of our population that is definitely at risk for not having a dignified birth. But we even have Serena Williams here. Serena Williams had a history of DVT, and many of you probably know the story because it was in the media. She had a history of a DVT. She had delivered, and she was saying, I think I have a blood clot in my lung. And she was ignored multiple times. And she finally demanded to have a CT. And on the CT, she was found to have multiple clots in her lungs. But just another example of not being heard. And then the doctor that's on the right, she's actually a physician. And in her story, she talks about not being heard. She realized that what the experience is that a lot of Black women are saying about their birth experiences. When she was saying that she didn't feel right, no one listened. Now, her birth experience, she didn't have a complication. She ended up doing well, but to the point of women want to be heard, and that should be, again, a human right. And so when we think about respect, these are just some quotes around respect. They don't have anything to do with childbirth, but just when we think about what does respect mean. So Jackie Robinson says, I'm not concerned with you liking or disliking me. All I ask is that you respect me as a human being. And then Lawrence Stern says, respect for ourselves guides our morals, but respect for others guide our manners. And so let's think about that as we think about how respectful maternity care takes place. Next slide. And so I would venture to say and argue to say that respectful care is patient-centered care. And so patient-centered care, I think, is something that we're a little bit more at least familiar with the term. So patient-centered care, defined by the Institute of Medicine, is providing care that is respectful of and responsive to individual patient preferences, their needs and values, and ensuring that patient values guides all clinical decisions. So again, thinking about a model of care where we are actually allowing the patients to have a voice in their care. Next slide. And so the Picker Institute's 8 principles of patient-centered care really tells us those 8 things that make up patient-centered care. And as I go through these, I want you to think about the charter that we talked about in the beginning, and you'll realize that all of these things really go back to the respectful maternity care charter from the White Ribbon Alliance. So it means having respect for patients' preference. It means coordination and integration of care. It means providing information and education. It means physical comfort, giving emotional support, making sure that our family and friends are involved. A lot of times we forget the family as an extension of the patient. It means continuity and transition, and it also means access to care. So again, if you think about that charter of respectful maternity care, it really aligns really well with patient-centered care. And on to the next slide. So patient-centered care is quality care. Now, there's not a lot of data on respectful maternity care. There's a little bit that shows that it does help with outcomes, but there is a need for more data. So I would encourage you, as y'all are beginning your initiative around respectful maternity care, that you use that as a time to capture the data to show improvement in outcomes. But if we agree that respectful maternity care is patient-centered care, we do have a lot of data on how patient-centered care improves quality. So it's been shown to improve patient outcomes. So again, for patients that are involved in their decision making, or involved in their care and involved in the decisions that affect their care, they're more invested, and so they're more compliant. And so you do see better patient outcomes. Those patients also have improved patient satisfaction scores, not just for them, but their families. They feel, again, they feel more satisfied because they are participating in their care. There's improved reputation of providers and healthcare systems. And so not only is this something that is important to our patients, but if we're thinking about this from a business of a medicine standpoint, because I'm not sure everybody's role on the phone call today, but if you are a CEO, if you're a chair of a department, it helps the reputation of your healthcare system to provide patient-centered care. There's also better allocation of healthcare dollars and other resources when we're doing patient-centered care. So we have less readmissions, we have less complications from surgical procedures, and so we're not spending healthcare dollars on complications, and so we have a better allocation of those resources. And then for overall, there's a better morale among the healthcare team when they're providing that patient-centered care. Next slide. So if we agree that, first of all, that respectful maternity care is a human right, and we agree that it provides better outcomes, what are those obstacles to getting respectful care? And so there's 4 big obstacles that I would convey to you today. One is bias, and so we're talking about on an individual level. The next is culture of a healthcare system, so now we're talking more from a system standpoint. The third is time, which is also a system standpoint. And then on an individual level, just the lack of familiarity with the respect model. And again, if we think about when we were trained as physicians, we were trained as nurses, it was largely a time when we were taught paternalistic medicine, where I am the doctor, I have all the knowledge, and so I tell the patient what to do. And so this really is a different way of thinking when you're thinking of involving the patient in those care decisions. Next slide. So a little bit to talk about bias. So implicit bias, and this is defined from the Khoury Institute, but implicit bias, also known as unconscious bias, these are the attitudes or stereotypes that affect our understanding, our actions, and our decisions in an unconscious manner. So these are not anything that we are, or decisions that we're making because of conscious or intentional decisions. These are unconscious. Okay, next slide. So why do we have implicit bias? Why did this even happen? Our brain is inundated with the amount of information that is coming to us at one time. We cannot possibly process all of that information. And so the way that we accommodate is that we seek out patterns and we use these patterns to take shortcuts. Again, we cannot process all of that information at one time. Unfortunately, the way that we seek out those patterns and take the shortcuts are through experience and social conditioning. And so basically we form stereotypes either usually because of passive exposure, either in the media or an exposure as children, but you develop these patterns and these ways of thinking and create these shortcuts. And so that when you see an individual that represents a particular group, then instead of making a decision about that individual, you make a decision about the individual because of the group that they represent. And then that can affect our care. And we see that all the time in our differences in healthcare delivery. Next slide. And so in addition to seeing differences in how we deliver care from our bias, we also see microaggressions. And so what are microaggressions? Those are our comments or our actions that subtly, often unconsciously or unintentionally, express a prejudiced attitude toward a member of a marginalized group, such as a racial minority. So this is a manifestation of implicit bias. Next slide. And so there's three types of microaggressions. And as we go through these, I want you to think about if you have had these happen to you. I want you to think about if you have participated in any of these microaggressions. So first we have microassaults. And so these are conscious and intentional actions or slurs. They come out of an unconscious stereotype or an unconscious belief, but the action is intentional. Now, what I mean by that is, for example, if I have in my mind as a bias that Black men are aggressive and I see a Black man walking down the street and I have my purse, then I'm gonna clutch my purse. That is an intentional action because of a bias that I have formed about Black individuals or Black men in particular. If we think about micro insults, these are those verbal and nonverbal communications, those subtle comments that we make that convey rudeness and insensitivity that is demeaning to a person's race, ethnicity, or gender. So for example, I will use some from my personal life as a Black woman. These are things that I've heard. You're so pretty for a Black woman. So while that may seem like that is a compliment, what you've really said is that Black women are not pretty. I am the prettiest of the non-pretty. And so again, these are conveying rudeness and conveying thoughts that are insensitive. Another type of microaggression we see is a micro-invalidation. And this is communication that subtly excludes, negates, or nullifies the thoughts, feelings, or experiences that are reality for an individual. So an example of a micro-invalidation is, I don't see color. That is, while meant to convey that someone is not being, I guess, racist, or they're not having any ill feelings toward any particular racial group, that is actually an invalidation. If you say you don't see color, then that means you don't see me. Before I am a physician, before I am someone's spouse, before I am someone's parent, I am a Black woman. You cannot look at me and see anything else. And so that is invalidating to say that you don't see me. And I go through these microaggressions and I go through these biases to say that we all have biases. We all have biases. Again, it is the way that our brain functions. And because of these biases, we all experience these microaggressions. And it would be remiss for me to not talk about it. And it would also be naive for me to think, or for us to accept the fact that once we walk into the hospital and we're dealing with our patients, that we just all of a sudden don't have biases anymore and we don't have microaggressions. But we do, and we have to acknowledge that, because that affects our ability to provide respectful care for all patients. Next slide. And so thinking about, we talked about now bias and how that it can be an obstacle to respectful care. think about the culture around respect in healthcare and in your particular healthcare system. So in a culture of respect, people perform better, they're more satisfied, they're innovative, they display a greater resilience. So we want to have a culture of respect. But respect is a two-way street. So we're not talking just about respecting our patients, but it's also about respecting each other. Me as the doctor respecting the nurse respecting the environmental services person, the nurse respecting her colleague nurse. So having that respect for each other creates a culture of respect. And it's been shown if you don't have a culture of respect, then you can't have patient-centered care. If I don't feel respected, it's hard for me to then give respect. And so this is a huge component of being able to have respectful maternity care. Next slide. So there have been, this is from some literature, but there are several categories of disrespect. And so I'm going to go through some of these just to kind of detail the differences in disrespect, because these are the areas that you want to look for in your facility and in your area where you practice. To make sure that you're not seeing or participating in any of these disrespectful behaviors. And I'm looking at my other screen to get my notes here. So disruptive behavior, I think this is pretty obvious. These are these egregious conducts, people throwing things and people pushing, having threats, angry outbursts. We don't see these very often, but this shows disrespect in the culture. Demeaning behavior. So this is when we're having shaming, when we're censuring staff in front of others, insensitive jokes, when we're making those little jokes about someone's race or their gender. Also sexual harassment, that is another form of demeaning behavior. These are actually forms of microaggression as well. Intimidating behavior, so that's having arrogance, sarcasm, when you're invading someone's space intentionally, you're getting in their face. That's intimidating behavior, and that shows disrespect. So passive aggressive behavior. So when you're refusing to do tasks, being unreasonably critical of authority, those willful workarounds, not only are these areas of disrespect, but these are areas where we can start to have patient safety errors, doing those willful workarounds. So passive disrespect. So this is being procrastinating, being always late, resisting safe practices. And then dismissive treatment is gossiping, being impatient, constant refusal to value others, to acknowledge others. And then probably what I see more often are nonverbal insidious behavior, sighing, rolling eyes, staring, glaring, making faces. All those things are ways that we show disrespect. And then systemic disrespect. So now we're moving from an individual respect and a culture or a group of people doing disrespect to the whole system has now developed a culture of disrespect, making patients wait, having, if you're a leader, having your team have excessive workloads, requiring long work hours. So all of the components that you see here make up a culture of disrespect. And so if your workers, the people that are working in your environment, don't feel respected, then they can't give respect. And so it's important as leaders that we are looking constantly for all of these areas and monitoring, policing to make sure we're not seeing signs of disrespect. And then next slide. Not enough time. So again, this is a component or not a component, but an obstacle of not being able to have respectful maternity care. So in a study that was done by Medscape, they found that 27% of OBGYNs spend about 17 to 24 minutes with their patients. 35% spend about 13 to 16 minutes, and then 27%, so a little over a quarter, spend only 9 to 12 minutes with their patients. Now, this is not because the physicians are all of a sudden just wanting to rush through, because the physicians also don't like it. So they report that the lack of time with their patients makes them have decreased job satisfaction, and it increases physician burnout. And so really when we're talking about this, so why do we not have enough time? So this comes down to our pay models. If we are in a healthcare system where we are where our providers are paid for volume over value, then they have to see more patients. And because they have to see more patients, they have less time. And to provide respectful maternity care, it takes time. You are trying to build relationships, and that takes time. And so we have to be careful and monitor this, as we know this can be an obstacle. And then next slide. And then the last thing I'll say as an obstacle, again, is thinking about the respect model. As I said, we as providers, most of us were not trained in a shared making decision model. We were trained in a paternalistic model where we know what's best. And so we tell people or tell our patients what to do. But if you apply the respect model, then that's thinking about having a rapport with your patients, having empathy, showing support, thinking about the patient model as a partnership, not just a I'm telling you what to do, but a partnership. Explaining things as a provider, having cultural competence so I can relate to my patients. And probably, even though it is the last thing on the list because it's an acronym, the foundation of the respectful maternity care model is trust. If I trust you, if I'm the provider and I trust the patient, then I trust the patient, then the patient, I will be comfortable with the patient having say so in her care. And if I'm the patient and I have trust, then I trust that when the provider is advising me, they have my best interests. And so again, thinking about this as a partnership. Next slide. So the pathway to change, how do we make this better? We've talked about why, first of all, what respectful maternity care is. We've talked about why it's important, why it's beneficial to individuals, to providers, to healthcare systems, even financially it is beneficial. And we've talked about obstacles. So how do we get there? And so we're going to talk about it from each of those components that make up the healthcare system. So providers, patients and community partners, the healthcare system, and then finally policymakers. And so next slide. So as providers, we have to start with ourselves. So as Gandhi says, be the change you want to see in the world. So you start with yourself. So it's interesting, this is a study done at Harvard, 60% of providers believe that the quality of care is different by race, but only 40% thought that that difference applied to their patient panel. So while we as healthcare providers understand that there is a difference in how healthcare is provided, we are not so introspective to understand when we are also participating in that difference. Next slide. And so along that, the first thing that you have to do is acknowledge that you have a bias. Again, everybody has a bias. It is a natural process. It is something that we can change, but it is something that we all have. And so the first part is acknowledging what your bias is. And I think I heard a mention of it today, but you can do the implicit association test through Project Implicit through Harvard. It's free of charge. You can check for lots of different biases. You can check for gender bias, for race bias, for just a lot of different biases that may exist, but knowing that you have a bias and acknowledging it is the first thing that you can do to start to fix it. And then there are ways to address your bias. And so this model here is one of the only published studies that shows that you can effectively do things to change your bias. Now, it's important to remember that as you're addressing your bias, it has to happen longitudinally. This is something that has to happen over time. Because if you think about it, this bias, this stereotype is almost like a habit. Just like I wouldn't say I'm a smoker and today is Monday, by Wednesday, I'm not gonna be smoking anymore. That's not how that works when you have a habit. So just like it doesn't end that quickly to stop something like smoking, the same thing about addressing your bias is something that has to happen intentionally and over time. So the first part is starting to see people as individuals and not the groups that they represent. The next part is understanding if you have a bias, is that bias founded in reality, or is it founded in a stereotype? 100% of the time I would say it's a stereotype, but understanding that your belief is a stereotype and not a fact. And then as you're trying to address that stereotype, it's not necessarily trying to undo the stereotype or try to tell yourself to not think about the stereotype. That's just like me saying, don't think about the pink elephant in the room. That's the only thing then that you're going to think about. Instead, it's about trying to replace that stereotype. So if I have a stereotype of thinking, you know, that overweight people are lazy, then I'm going to then start thinking about what overweight people do I know that are not lazy, that are active, don't procrastinate, that are always motivated and always moving. That's the way that you start to then replace that stereotype. And then increase your opportunity to have contacts with individuals from different groups. Again, the way that we usually form our stereotypes are passive interactions through things like media and not actual interactions with individuals that represent those groups. So try to increase your opportunities to have contact to start having different thought processes. And then above all, and this is a foundation of respectful maternity care as well, is about having empathy, trying to put yourself in someone else's shoes. And the next slide. So we've talked about it as providers, but thinking about it from patients, from the patient and community partner standpoint. So keeping patients at the center of innovations of care. So as you're thinking about how you're going to do care, how you're going to deliver care, instead of me designing a system around me, I need to design a system around the patient. And the only way I'm going to know what that system needs to be is to talk to the patients. Latasha Rouse, who I believe may be speaking after me later today, has a saying that she said with us, with our LAPQC, family-centered care is not something you do for a family, it's something you do with a family. And so we have to stop thinking about the care that we give for our patients as something we're doing for them. It is a partnership. It is something we're doing with them. And so we have to think about, again, our patients and our community partners and have them help us design how that care should take place. Next slide. And then again, in thinking about the patients as partners in decision making. And as I've mentioned multiple times now, this is just for providers, it's just a different way of us thinking because it's not how we were trained. So there's 3 different models of care. What we're trying to get to is partnership. What most of us practice is prescriptive medicine. The healthcare provider creates the plan and provides to the patient, which the patient may or may not follow. The patient has no investment in that plan. We haven't even gotten feedback from the patient to see if it is a plausible plan. But this is what we mostly practice. And then we wonder why our patients aren't compliant with our care. We just want to say they're non-compliant. It's not always that patients are quote unquote non-compliant, is that we've given them a plan that they have no investment in. And so we get better when we do a shared decision-making model. And I think some of us have transitioned to this. And this is when the healthcare provider and the patient develop the plan together, but the patient's roles, responsibilities are not really included. So we've kind of decided how things should go, but really we haven't discussed roles and responsibilities and accountability. Partnership is where we want to go. And I see few people practice this way, but partnership is where we want to go, where there is a mutual agreement on the plan and the decisions and a shared accountability. Accountability on my part as the physician, but also on your part as the patient. And the next slide. And then healthcare systems, again, thinking about how we can get to those areas of respectful care. So we have to explore different pay models for care. Again, like I was saying before, we have to move from volume-based care to value-based care. If your providers feel that they're always on a time crunch and they have to see so many patients, or if they don't do the delivery, then they don't get credit, they don't get the money, then it's really difficult to move to that respectful care model. When you are moving to a model where you're paid for your value, then you start to practice in a way where you are increasing value. And we have to create systems with more that promote a culture of respect. And so that means accountability. So again, if you're seeing those disrespectful behaviors that we talked about before, what is the level of accountability? If I am that nurse and my manager is constantly in my face, who do I talk to? Who is she accountable to? What is the way of reporting that? It's about engaging and supporting from leadership. How do you engage and support your providers, your nurses, so that they feel respected, so that they feel engaged as well. And then again, it's about partnering with our patients. It's about partnering with our families, again, to create this culture of respect so that we can then provide that respect to our patients. And then next slide here. And I forgive me, I didn't include the kind of the policy part of this, but it's also talking to our payers so that they are paying for value instead of paying for volume. As they change their way that they reimburse facilities, then facilities can also change how they reimburse their physicians. And then there are some tools to measure respectful care. So the mother's autonomy and decision-making scale is one way. And this is kind of evaluating, it's for patients, and it's a chance for them to evaluate how much say they had in the decision-making around their care. And then the Mothers on Respect Index is one that measures if women feel respected, if they feel that they had any signs of implicit bias towards them or explicit bias, then that is something that comes out in that scale, as well as the mistreatment index. And I've provided links to these scales in the references part of the lecture. And then next slide. And so in summary, respectful maternity care is necessary for quality and safety. It's important. We have to always recenter the work to the who and the why. And we have to make care equitable by making care better and consistent. And then I'll leave you with again, just in thinking about respectful care and what this means and all the times that we see it and all the times that we don't see it. So this picture that I have here is intentional. The lady on the left is Simone, and the lady on the right is her birth coach, Latona. I do know Latona, I don't know Simone, but I do know the author of this story. This was in the New York Times, and I do know the author who acted as Simone's surrogate during her childbirth story. So in Simone's first birth, she unfortunately delivered around 20 weeks. Of course, we know that's pre-viable. She had a postpartum hemorrhage. And so she experienced loss in a lot of ways, being in the hospital longer, having the complication of a hemorrhage, all of that, and then losing her baby at the same time. Now, contrast that to the second birth. The pregnancy went fine. She didn't have any issues. Latona was with her for the whole pregnancy. She gets to the delivery time. And for our intents and purposes, we would say she had a successful birth. She had a vaginal delivery. She did fine. The baby did fine. She went home on postpartum day number 2. No complications. But I would venture to say that Simone felt as much loss in that second birth as she did in the loss of her 20-week fetus, because she talks about her birth experience. And she says that the doctors, the nurses, they talked around her. They talked to each other and did not talk to Simone. When the change in plan or the birth plans changed, they didn't ask Simone about it. When they were doing her checks, there was a resident with a medical student. They didn't ask Simone if it was okay for a medical student to be there or for a resident to be there. They talked to each other, didn't involve Simone, didn't talk to Simone. And so she felt just as much loss in that second birth as she did in the first. And so I think as providers, we think the end goal is to have a healthy baby and to have a healthy mom. And that actually is just the bottom bar of the goal. And so for me, I think about my birth story and I think about the fact that I look like Simone. Now, of course, I'm a physician in the hospital where I deliver. And so I had a great birth story, but I had a great birth story in that I was respected the entire time. But I think about if coming into the hospital, if I was just Veronica and I wasn't Dr. Gillispie-Bell, what would my birth story look like? And so I think it's important for us to understand that our privilege sometimes gets us things that it shouldn't. And privilege, I have privilege, even though I don't have privilege in every situation. As a doctor in the hospital where I'm giving birth, that provides me privilege. But I would leave you with understanding and thinking about the fact that privilege should never be the gateway to respectful care. And so think about that as you go back to your hospitals and you think about really those women that are the minority, whether they are the minority racially, they're the minority socioeconomically, thinking about the women that I talked about that gave birth in a jail. All women and babies deserve as a human right to have respectful maternity care. And with that, I will be happy to answer any questions that the audience may have.
Thank you very much. We have about 15 minutes for questions. If anybody has any questions, if you want to either raise your hand because I've muted everybody, or you can type your chat or your question in the chat for her. And I want to say thank you very much, Dr. Gillispie-Bell, for speaking today. I have received probably over 15 private messages saying how awesome you are, how especially helpful this presentation has been, even given our current climate. This is a perfect lead-in to what's coming for the rest of the session. We planned this. And let me see, but overall, another one, this is a great session, amazing correlation. So I definitely thank you. But please, let me see, it looks like we have some chats coming in. Another great presentation. Jackie Jones asks, have you seen a difference with doulas since COVID?
Yeah, so that was definitely unfortunate. I think COVID was very difficult for a lot of reasons, but for our birthing mothers, I think that it was really, really difficult in not being able to have that choice of their companion. Much like the rest of the nation, every hospital is kind of been doing their own thing around COVID. I know from my particular facility that I deliver at, that I do deliveries at. In the beginning, when the shutdown first happened, we did not allow doulas. We only allowed one birth person, and that could be whatever support person a mom wanted to have there, but it could only be one. And again, having to balance out the need to support our moms, but also to not wipe out our workforce. Even I was not allowed to be there with my own patients. We worked kind of the same way we do hurricane duty, because we have lots of hurricanes in Louisiana, where we had a team A and a team B, and whoever was on the team was the one that was able to do the deliveries at the time. I did touch base with all my patients, and they were very pleased with their care, but definitely a change there. After about a month, we did start allowing doulas to come back into the facility, only doulas and one support person, because we do appreciate and understand the importance of doulas as patient advocates, as well as support during the labor process. It just was really hard during COVID, trying to also balance what we know mitigates epidemics.
We have another question. Have you used any of the measurement tools for respectful maternity care in your institution, or do you know how other organizations have used those measures?
It's a great question. I have not used them myself, and I don't know of any institutions I don't know of any facilities in Louisiana that have, but in the references section, where the link to the tool is there. There's some studies of some other places that have used them. They use them to validate them.
Okay. We have another question, and I'm not going to give the name. They're considering, have you or have anybody else considered switching out the word mother or mom for an ungendered word?
We usually use birth person instead of saying mother. I do tend to slip my southernness, I'm sorry, but we usually say birthing persons, and all of our literature for the Perinatal Quality Collaborative says birthing persons.
Okay. Another great presentation. Thank you for the outflow on microaggression. Wonderful presentation. The one area where I see a lack of respect is in the clinic arena when patients show up late.
Oh yeah.
I see quite a lot of disrespect for these women and have to forcibly say that of course we will see her. How do you handle these in your institutions?
Yes, so a lot of these changes that need to be made have to come from the top down. So I will say that. It's as an individual in my clinic, there's one way that I would like to handle it, but because our chief medical officer has said everybody gets seen, even if they're late, then now it's not so hard for me to enforce that. My policy has always been, I will see, as long as I don't have to leave to go get my son from school or, anything like that, I will see anybody that comes in. I think that we forget as providers how we just don't, again, it's about putting yourself in someone else's shoe. When I have to go to a doctor's appointment, I jump in my car, I drive to the appointment, and boom, I'm there. I have patients that have to take 2 and 3 buses in New Orleans to get to see me. If you've never ridden a bus, you have no idea what that experience is like. Having to wait on the bus is sometimes late. Now you miss the second bus. So you have to consider, people are not always late because they just don't have anything else to do. And so I think it's important, as it was mentioned in the comment, that as we are respecting everybody, again, putting that empathy, putting yourself in someone else's shoes and making that allowance so that you are able to take care of those patients. So from models of care, like I said, I see anybody, even if they're late. I tell them they may have to wait a little bit because I have to see some of the other people that came on time, but I will work them in. The other thing I do is use my partners. If I have partners whose schedule is not so busy, then I will offer the patients as well if they would prefer to see my partner instead of waiting, but we don't turn anybody away.
Excellent. What leaders or stakeholders within your own organization did you initially reach out to in order to begin working on this initiative? And did you start in the C-suite or within the OBGYN department?
So I would say from a patient safety quality improvement standpoint, actually, if y'all don't mind, well, I won't mess. I have a slide about stakeholder analysis that I think is really good. So the first thing is to figure out who all your stakeholders are. And then you need to categorize them. So for those stakeholders, who is a high stakeholder? So that, like, if they don't get on board, you can't do it. And who's a low stakeholder, who has a lot of influence and who has a little influence. Once you start to categorize them, then that helps you to figure out who to approach when. For example, if you want to talk about the C-suite, they have a lot of influence, and maybe they have a lot of influence and they're also very, very engaged. Then you would want to engage them first because they'll be able to set the rest of the motivation for doing the project. But it's really, again, it's about trying to categorize the stakeholders. I mean, for us, it's about the nurse. We have kind of a safety team, a quality improvement team, I guess I would say, nurses, providers, anesthesiologists, our midwives, kind of our boots on the ground people. And so we kind of initially thinking about patient partnership in particular, we kind of met with them first. We decided that was something we wanted to do. We developed a patient partnership program where we have brought in patients to hear their story, to hear what their care is like. And we took that message to the C-suite to help motivate the C-suite. We had to get permission from the C-suite to do the patient partnership, and there are other patient partnerships that exist. in different ways. And so they were kind of on board because of those partnerships, but it was having the partnership and then feeding that back into the C-suite or our executives, not the executives of the department, to say, these are the issues and the problems, to then start getting some changes to take place.
Excellent, thank you. And if you want to share that slide, I'm happy to share it to everybody. Did we lose you? Okay, there we go. We froze.
Oh, sorry.
No, you're okay. Another question was, do you find that teaching hospitals are more difficult to provide the respectful care model as opposed to non-teaching hospitals or facilities?
I don't know that I would say that teaching or non-teaching facilities is the delineating factor. Because I feel like a lot of non-teaching, at least in Louisiana, a lot of non-teaching facilities, there is no doctor at the hospital during most of the maternity care. It is just the nurse and the patient. I think in teaching facilities, it just depends. It depends on how you treat it depends on the culture. It depends on how you treat your residents. It depends on what you have taught them on respectful care. Again, when we think about those components of a disrespectful culture, if it's one where the residents are afraid because they're always being yelled at and they're being shamed, then you have a culture of disrespect, and then it's not going to be a respectful model. So again, I don't know if it's teaching or non-teaching as much as it is the culture in the facility.
Okay, yeah, that makes an excellent point. Another question, do you know if the respect or mistreatment tools have been used to compare patient satisfaction with or without the use of doulas or midwives? So in comparison.
I haven't seen any, I've not done that, and I haven't seen any studies looking at that, but I think that would be very, very, very interesting.
Another, and this is what brought me to you, was the phrase, privilege should never be the gateway to respectful care. So another person captured on that and couldn't agree more. And I think the other one, we just have a statement as far as they're aware of a hospital in Nashville who uses the respectful maternity care model and has all of their employees sign a respectful maternity care contract upon hire. Something we could look at possibly doing here in Virginia. Do you know, or do you use something similar to that, or have you heard of it in other situations?
So it's not something that I don't know of any of our birthing facilities that use it in Louisiana, and we don't require it through the Perinatal Quality Collaborative. I know that California is working on something very similar, and they have, California is a very interesting state because they have a lot of legislation that allows them to do some things that we can't do, definitely in the South. But that's the only other place that I know of that has some type of an agreement that they do with facilities.
Okay, and one more question, unless they fill up again. If you do not have an administrator or culture that is receptive to this approach, do you have any suggestions on how to move this forward on your own?
So that's interesting. So if you don't have an administrator, I mean, you can always start, if we think about the obstacles and we think about, again, the model, the pathway, it starts with me. So you can always just start with yourself. You can police as well when you start seeing those microaggressions, because again, those microaggressions are part of the culture of disrespect. So you can, start with you, start a small, I hate to say like a grassroots, but there are more, I will say, in doing this work and doing health equity work, there are more people that are doing the work than you realize until you ask the question. So I would say start with you and start asking around. There are more people probably that are invested than you think. And then eventually, as you start asking, there are probably administrators that are also invested in that you just are not aware of, and they can help move that message forward as well.
Or Leslie, who asked the question, if you want to reach out to me, we can see about other hospitals, neighboring hospitals that are doing this work, or we could maybe do it from that approach too. So we're all learning from each other. We can all benefit from each other through the collaborative. So you're not alone. You should never be alone now.
Absolutely. So. And use some of the tips in the, if you're trying to get your administrators on board, use some of the tips in the presentation. It's to their, hospital administrators live and die by their reputation. first of all. And there is data, good data that shows that this helps with the hospital reputation and the patient satisfaction scores, which are all hospital administrators also live by, because there is some financial implications for that too.
All right. I don't see any other questions. I want to say thank you very much. Having my son in Louisiana, Louisiana is near and dear to my heart.
Yes.
Military hospital. But anyways, I thank you very much for joining us. I can't say it enough. So we've enjoyed your presentation. So
thank you. Thank you. Thank you. Thank you. Thank y'all for having me. Thank you for having me. See y'all later.
Bye. Thank
Bye.
you. All right, without further ado, we are a little ahead of schedule, so we can go ahead. I need to clearly, sorry y'all, I'm trying to go back to presenter mode. We can go ahead and go to break. We are coming back at 2:10. I believe that's what our agenda says. Yes, break until 3 o'clock. We're a little bit over, so go ahead and we can be back at 3:05. Please, please, please stay logged in so that we don't have to unlog and relog back in. But go ahead and you can turn your cameras off for now, and I will see everybody back at 3:05. Thank you. will begin in about 1 minute.
Okay. Hi, everyone. Welcome back. Our next speaker is Megan Buchholz. She comes from Santerre Norfolk General Hospital. She's going to talk about respectful care initiatives, hospital to home for healthier Hampton roads. Megan?
Guess I need to unmute myself.
Yes. Thank you
Hey,
for being
everybody.
Hi.
Thank you. Thank you, Dr. Khoury. So yes, my name is Megan Buchholz. I am the Director of Women's Health at Santerre Norfolk General Hospital. And I am here today to present an initiative that will be starting working with a community agency in the transition from hospital to home here in Hampton Roads, and very excited to share this project as it's kind of been a dream of mine for a while, and very excited to see it potentially come to fruition and what the data will show as we do this. Next slide. So wanted to share a little bit about what is my why. So as we come to these yearly meetings and then other meetings, we hear all the national data, the Virginia data, and the maternal mortality rates, the morbidity rates, the neonatal morbidity rates, and we always leave there thinking, I'm going to do something about it. And I want to make a difference. I want to fix something. I want to start something. And I know that if we were sitting in a big room like we were last year with 300 of us, that I would see a lot of head nods and that y'all would agree with me that we want to make a difference. And as the weeks go by and the months go by, we go back to those meetings and we think, doggone it, the data hasn't changed that much and we haven't really made that much of a difference. What do we do? How do we do that? And as Shannon shared, a lot of us are in the hospital and most of us don't see those health issues occurring in the hospital. They're occurring after those patients go home. So we kind of feel helpless, and at least I know I do. So I know here at Norfolk General, we have staff that come up and say, you know, we have patients that are starting to express, because the data is out there. It's on the news, it's in the papers, it's all over the internet. Patients are starting to say, I'm afraid I'm going to die. Especially if they're Black, they are expressing a fear that they are going to die. And the nurses will say, not on my watch, I'm not going to let you die today. What I've included on this slide is data from the VHHA from 2018 and 2019, what our Norfolk General race distribution and payer distribution looks like. So as you can see, we have a significantly higher number of Black patients than white patients, and we also have a significantly higher volume of Medicaid patients. So we know from the data, and SMFM has put out there between 2011 and 2015 that Black women are over 40% at higher risk to die from childbirth-related complications than white women at 13%. Black infants are more likely to be born early if their moms live in a segregated neighborhood. And Black infants are also twice as likely to die within their first year as white babies. So what do we do about that? Next slide. So Virginia Hospital and Healthcare's Association started a project by inviting several hospitals in the state. I believe it was 12 hospitals in the state, Centera, Bon Secours, and several, Centra, I believe, and several other independent hospitals to start some brainstorming to look specifically at maternal morbidity and mortality and start some brainstorming sessions. And we started, I believe it was about 18 months ago, and I'm losing track of time because of COVID. And we started looking at data and kind of talking about this big idea of how do we fix this? And talking about upstream projects versus downstream projects. And Lauren and Polly at the VHHA, if any of y'all have had the pleasure of working with them, you know, they were really excited about looking at upstream projects and how do we really educate patients before they get to the hospital. Let's get them healthy and let's keep them healthy, and let's work with our community partners and get them healthy before they come into the hospital. And that's awesome. That's a great idea. So I'm sitting there in my chair and I'm thinking, I don't know how to do that. That seems really foreign to me. And so as I'm looking at my data, the picture you see on the slide is the zip codes that Norfolk General serves in Virginia. This does not include North Carolina, just in Virginia. And that's over 150 zip codes that we served in 2018, 2019. So if we're supposed to do a project that's supposed to collect data on a small group of patients, I can't just do a couple zip codes in Portsmouth or a couple zip codes in Norfolk, because patients come from all over the place. We're the regional transfer center. We have a high-risk patient population. But what I do know is I know the high-risk patients that I'm sending back out the door into the community. So I want to go rogue, which isn't, if you ask any of my team, that's not an abnormal thing. So I call my friends at the VHHA and I tell them that I want to go rogue and not do an upstream project. I want to do a downstream project. And I want to try and make a difference on postpartum patients that we're sending back out into the community. But I don't know what that looks like. So then I have a moment. So I'm going to tell you a story. Often as leaders in the hospital, we deal with customer service issues. And there was a particular day that I was dealing with a patient who had significant customer service issues, and she had lots of complaints about her care. She didn't understand a lot of things that had happened during the course of her care, and a lot of it was due to miscommunication. A lot of it was due to a lack of understanding, and both physicians and nursing, it appeared, had not done a great job of explaining what was going to happen to her and the course of care. Just a lot of things happened along the way. Her baby ended up in the sick nursery. She didn't understand that. Again, a lot of miscommunication, a lot of opportunities for us to do better. And so as I was taking note of this, and of course trying to fix it because she had already been discharged, it was several weeks later, and the physician and I were asking her about her medications. And she said, I don't know. Well, the interesting thing was, in the course of conversation, we found out that she had had a follow-up with a cardiologist because she had multiple comorbidities, and he had discontinued one medication, started another, and she had been discharged on 9 medications, wasn't even taking one that she was supposed to. And I said, hold on, I'd like to go back and check in your chart and see what you're supposed to be taking, and I'm gonna call you in 30 minutes. Is that okay? And she said, well, I'm not sure I'm supposed to be taking this because I'm breastfeeding, and nobody ever answered that for me. So when I called her 30 minutes later, she only knew about one of the 9 medications, and one of the ones that had been added, she wasn't taking at all. And simple things like ibuprofen, she didn't know is the same thing as Motrin, or that it did the same thing. And I spent 40 minutes on the phone with her talking about the importance of taking her Lovenox until it was gone to prevent DVTs. I talked to her about taking her Lasix until it was gone because it was important for her heart. And it was this aha moment that I thought, this is maternal mortality staring me in the face. This is one patient that didn't even really care about her medication issue. It was a customer service issue. But she could have been a maternal morbidity and mortality statistic in a week or two, and we would have never even realized that there was a concern. And anyway, we got all of her meds straight. She wrote everything down. She set alarms in her phone, followed up with her a couple days later, and she had refilled the meds that were important, and it all got straightened out. But that was the moment that I said, this is what my project needs to be about. It needs to be about these patients that don't understand when they're leaving the hospital why they're taking what they're taking, and they need a follow-up before they get lost in the system. So because we can't see all the patients, we have a bandwidth that it's just not logistically possible to see all the patients, because we do about 3,300 births a year here. So we kind of condensed it. Our initiative is that we will take all of our patients that are discharged home on an antihypertensive medication. They'll receive a referral for a home visit from a nurse between weeks 2 and 6 of their postpartum period. Most all of our patients, in talking with the office, will go to their 1 to 2 week blood pressure check visit at the office. It's that 6-week visit that they fall off. They don't go back for various reasons: transportation, their baby, other family concerns. They just aren't as worried about taking care of themselves. So we're going to try and stretch it out into the weeks, between the weeks 2 and 6 of their postpartum visit. So it has been proven that home visiting does get results. There's better birth outcomes when home visiting is started early. The parents interact better with their children. There's better use of resources. There's lower hospitalizations. And so what the nurse will be checking when she goes out to do a home visit will be their blood pressure, their medication list. They'll be checking on breastfeeding if that's something that this mom plans to do, and all the other social factors. They'll be checking for depression. They'll be looking at the home environment. They'll be checking for safe sleep. They'll also be looking at food equity, housing situation, job status, and all of those social determinants of health, and seeing if these families need help as a comprehensive overall assessment. Next slide. So part of the VHHA initiative is that the hospital is to partner with a community agency. And so once the project was solidified in my brain, I initially thought of CHIP. And CHIP is the Children's Health Investment Program. Many of you are familiar with CHIP, whether it's CHIP of Virginia, but we have a very strong CHIP chapter here. And the reason that I chose to partner with CHIP is specifically because of their CEO. Trish is absolutely phenomenal, and I met her in working with her on other committees, and she is extremely passionate about maternal child health. CHIP itself already has a home visiting program established with nurses. They have a good reputation in the community. They believe in the entire family component and that it all works together. They don't just see the baby, they see the mom and the dad and the partner, and whatever the family component looks like, they work with that family as a team. Whether it's a single mom, whether it's 2 moms, whether it's a mom and a dad, whatever that family component looks like, they work with them as an entire family unit for optimal health. Trish and I also have similar goals and values. She's not going to start something and just let it fall by the wayside. And her team knows what community resources are available. They're going to do what it takes to see a family succeed. And they do have a large footprint here in Hampton Roads. So when I called Trish to tell her about my idea, there was silence, and then there was this gasp, and it was like, oh my gosh, oh my gosh, when can we start? And she was so excited that it's just like this perfect marriage of hospital and community, that we're both so passionate about these families succeeding in the community and making sure that they have what they need. So I'm very excited to partner with Trish and seeing what we can do here in Hampton Roads. Next slide. Oh, you are on the next slide. I'm sorry. I'm looking at my cheat sheet. So we had to identify our key stakeholders, and Lauren, I know you're out there. I have included a few extras since I sent you my charter, so I'd like for you to take note of that. So obviously Chip of Southampton Roads is the key stakeholder as my partner. And then Chip of Virginia is another key stakeholder. So Trish has actually already contacted the mother company, Chip of Virginia, and they would really, really like to see this project succeed and duplicated throughout the state. So we're really excited about that. Our providers, the EVMS providers, are certainly stakeholders, as it will be their patients that are being seen after discharge. They are certainly going to be interested in knowing how many additional visits they'll be needing to see patients, and receiving phone calls if there's anything found in the home that they need to be concerned about. Obviously, Norfolk General Administration are stakeholders, as this project will be taking up my time, as well as readmission rates and ED visits. So we're hoping to decrease ED visits and decrease readmission rates. Often once a patient reaches the, 3-6 month mark, they don't really admit that they've been pregnant in the past 3 or 6 months. So it's really hard to capture that sort of data because it's not typically questioned in the ED. So that data is going to be very hard to capture, but hopefully, I don't know what we'll do with that. VHHA is certainly a stakeholder, as this is part of their baby. Medicaid and insurance companies are going to be stakeholders as we see where this goes, and hopefully prove that this is positive. And then legislative leaders. We'd like to show that this is a benefit for patients in the postpartum period. And then our biggest stakeholders are certainly going to be the mother, babies, and families in Virginia. So barriers, these were barriers that we thought we would have. Manpower for referrals. And so we're engaging our own nursing staff, showing them the importance. Quantity of nurses for home visits. So we anticipate we will have 30 to 40 nurses per, or 30 to 40 visits per month. So we've applied for grants and will continue to apply for funding. Quality control of data collection. So we've got scripting that we'll use and using computer-based data collection programs. The data exchange between the hospital and CHIP. So we've got a memorandum of understanding and progress, and the patient will sign a release of information. And then there are other programs with similar services offered, but we wanted to really have the ability to collect our own data and review a specific population. So that's why we're doing this. Here are key metrics. So a lot of key metrics. The two bold ones, number of visits per patient. The patient will continue to be seen if there are issues. So if they are not well after the first visit, they will not drop off. They will continue to be seen. And the number of patients who obtain connection with a PCP. Often a patient only sees their OB provider as their PCP when they're pregnant. And so one of the goals will be that they have an appointment with an actual PCP prior to the end of the first year postpartum. So those are two of our primary goals. Next slide. What's next? We plan to start 2021. We will continue to apply for grants and funding. We do have one nurse in place that will start next month. continue to raise awareness and making sure that our data collection capability is in place. So the goal is to duplicate until all mothers in Virginia receive at least one home visit and multiple if their health requires. We're going to train nurses and certified doulas to assess for complications of pregnancy in the postpartum period to increase the workforce, and we hope to reimburse home visitation programs as part of regular maternity care. And Virginia will set the standard across the United States for the lowest postpartum maternal morbidity and mortality rate, using home visitation as a best practice. In other words, we'd like to change the world starting in Virginia. Thank you so much for having me.
Thank you very much, Megan.
Absolutely.
And unfortunately, we don't have time for questions for Megan, but she did an excellent job highlighting the work and initiative that Norfolk is undertaking. I would love to have you back again, Megan, maybe in a webinar series to where we would have an opportunity to kind of do some more Q&A. But if you do have specific questions for Megan, please put them in the chat box and I will make sure she gets them, and then I will follow up with everybody with your questions. So I do see a couple of questions in there regarding postpartum nurses and who's doing the home visits, and then the decision between the number of weeks. So continue to put your questions in the chat if you have any. So without further ado, I want to introduce you to our next speaker. And sorry, okay, sorry, I was asking me if I needed to mute everybody. And so, funny story, it took me, the steering committee can all laugh at this, it took me about, I don't know, 4 or 5 weeks to say the word Ariadne Labs, but I can definitely say it now without stumbling or asking Donald or Joe to complete the sentence for me. So we have the pleasure today to hear Ariadne Labs as they talk to us about the Delivery Decisions Initiative, and I'm sure Victoria will go into it a little bit further, but they actually did provide some of the initial training that was available through the Maternal Health Collaborative that Megan was able to participate in through her hospital. So I will turn it over to Victoria, and I'm trying to unmute you right now, Victoria. Can you unmute yourself? Okay, there you go.
I think I'm good. Thank you so much. Our team is so happy to be here today. It's actually not just me. I'm here with my teammates Avery Plow, Dr. Amber Weisseth, and Dr. Neil Shaw. So Amber, as long as you're ready, you can go ahead and get us started.
Great, thank you, Victoria, and good afternoon, everyone. Thank you so much for having us. I know your day has been full of talking about the opportunity and really charge to Virginia that lays ahead, as well as really focusing on respectful maternity care. It's something that we care a lot about. It's something that we've tried to invest our time and resources into operationalizing it so that every patient gets that every time. So we look forward to talking you through our experience with TeamBirth, how it was designed, a little bit about our testing, and then what's going to happen in the future. Next slide, please. All right, on this slide is our learning objectives, but I really want to see if we can get time at the end for Q&A, so I'm going to skip by them and not read them to you. So go ahead and go to the next slide. Again, here's our agenda. We'll go background really about TeamBirth so you guys at least understand what the components are, a bit of the testing, and hopefully, as promised, we'll have some time for Q&A. Go on to the next slide. Nothing to disclose. And next slide. Neil, you can get us started here.
Thanks, Amber, and thanks to all of you for being a part of this afternoon and sort of hanging with the long day. Let's go ahead and go to the next slide. I'll just start by giving some background on what Ariadne Labs is. And Shannon, don't worry, you're not the only one who doesn't know how to pronounce it. We have a holiday party every year where it comes up, and I think we actually change the pronunciation ourselves every once in a while. There's at least 3 different ways across the lab. But Ariadne was the Greek goddess who helped Theseus navigate the Minotaur's maze. And the reason that we picked her as our namesake is because we think about one way of improving healthcare is about helping people who are on the front lines of delivering care navigate the complexity of their jobs. And our vision is for health systems to deliver the best care for every person, everywhere, every time. And that obviously is a lofty, big picture vision, but it really signals our interest in developing solutions that can really work across contexts, in cities, in rural areas, in the United States, and even abroad. So let's go to the next slide. The way that we think about developing solutions is through this innovation pathway that we call the Ariadne arc. And it starts with designing solutions that are capable of working in lots of different places. And then we work on testing them, and we're going to talk a little bit about that. And then we work on scaling them up. So go to the next slide. This is just a signal that we work all over the world, everywhere from Texas to New Zealand. And you know, the index project at Ariadne Labs was the surgical safety checklist, which I know a lot of you are familiar with. But in the same way that a pilot has to run a checklist before hitting the throttle, a surgeon has to run a checklist before starting an operation and picking up the scalpel. And this checklist does not seem like rocket science, but it drops mortality in half for every surgery on every continent, and now is being used in hundreds of millions of operations across the world. And we're going to tell you a little bit more about TeamBirth, but it was developed with very similar ambition. The idea that it could be a very simple solution that does not seem like rocket science, but could have that kind of impact on hundreds of millions of people across the world. So go to the next slide. Fundamentally, what we think we do at Ariadne Labs is align what we call process with purpose. So there are so many things in our daily lives, and particularly on the front lines of healthcare delivery, where we have like a fork in the road kind of choice between doing the right thing and doing the easy thing. And so often they don't align. When it comes to childbirth, you know, you can sort of think about the person you're caring for that has a really protracted latent phase of labor, who has a category 2 tracing, who has high blood pressure, who has a fever, and all those things combine to make it harder to continue to support her and extend the length of labor. And the easier thing is actually just to do the C-section. And part of what we try to think about is how we can create systems that actually make doing the right thing the easy thing too. For the next slide. Amber and Victoria and Avery and I are part of one of our core research and social impact programs at Ariadne Labs that we call the Delivery Decisions Initiative. Our vision for this program, which is the motivation for everything that we're going to talk about next, is a world in which every person can choose to grow their family with dignity. And that vision statement is really a way of signaling what we feel are our values. And the fact that really, you know, almost every form of social injustice shows up in childbirth. This is true in terms of gender equity. It's true in terms of racial equity. It turns out an American today is 50% more likely to die in childbirth than her own mother was. And so it's also true in terms of generational equity. This idea that every generation should leave things as well as they found them, but when it comes to childbirth, this is actually a space where we're not doing that. And if you're Black in our country, you're 3 to 4 times more likely to die. If you're Native, you're twice as more likely to die. And that's not right. And so that's a big part of the motivation of what we're trying to do. So we can go to the next slide. And we can click 3 times. So this is one of our friends and colleagues, Charles Johnson. Many of you have probably heard his story. He lost his wife, Khoury, during childbirth 4 years ago, and has since then become a really important advocate in our country who's driven a lot of the even federal legislation to try to address some of these issues, having experienced many of these injustices himself. And Charles is Charles IV, and his son is Charles V. He's somebody who thinks a lot about this problem of generational justice and racial justice and how they come together. And you know, I put his image on this slide both to remind me and remind all of us of why we're doing this, and also just to highlight, you know, if you were to take one huge step back and pick 3 statistics to describe what has happened generationally in the American healthcare system, it's that we intervene in childbirth with major abdominal surgery 500% more. Term infants, who the surgery is designed to save, are 0% better off on average. and moms are 50% more likely to die. It's a pretty tough set of statistics. Let's go to the next slide. And fixing that kind of generational challenge at that order of magnitude is daunting, to say the least. So what we've done over the last couple of years is brought together the best thinkers that we could find across a variety of perspectives, and that's really the key. This is an image from one of our design sessions back in 2017, which I can't even believe how long ago that was, but it has representation from ACOG and SMFM and A1 and ACNM, all the different professional groups, as well as people representing the perspective of birthing people themselves, as well as people that brought different types of disciplinary lenses, people who are experts in design, industrial engineering, to try to think about what a solution might look like. So you can go to the next slide. And I'm going to turn it back to my colleagues to tell you a little bit about what TeamBirth is specifically.
Thanks, Neil. And if you go to the next slide, that will be our starting point. So throughout this design process that Neil mentioned, one of the key things that really anchored us as we were developing TeamBirth was a logic model that we're going to build out here together. So first, as kind of a vision statement, TeamBirth aims to provide a structure for effective communication, teamwork, and shared decision-making through labor and birth, through team huddles and shared visual communication tools. So you'll see both of those as the inputs to this logic model, where we have teamwork really anchored by these team huddles, as well as simple, effective communication anchored within this shared communication tool. And next slide, please. And these are supported by implementation, coaching, and feedback. One of the key parts of TeamBirth that one of my colleagues will show you in a moment is a very simple whiteboard that really anchors that communication and provides that simple communication structure. But we know that the whiteboard alone is not enough to create behavior change, which is why this implementation process is so important. And from that implementation, coaching, and feedback, that behavior change we're really looking for is this improved communication and teamwork that we really believe is essential to providing effective care. And finally, on the next slide, you'll see the outcomes we're working towards, which is both improved dignity in childbirth as well as improved safety. And you'll notice here that we really see dignity not as a secondary luxury or something extra that's being added on, but really as a core component of safety, where you're having this effective communication, you're honoring a birthing person's preferences, wishes, and that really contributes to both a positive experience, patient satisfaction, as well as ensuring that they're receiving safe and effective care. And on the next slide, you'll see we're going to use this logic model as really the anchor for our discussion of TeamBirth today. So I'm going to hand it over next to Victoria and Amber, who are going to talk you through a little bit more of the details of how these ideas of teamwork and simplicity play out in the TeamBirth tools.
Great. So as Neil and Avery touched on, when we were designing TeamBirth initially, we really focused on these two core design principles, simplicity and teamwork, which we believe are essential to delivering high quality care consistently and reliably for every patient, everywhere, every time. And the reason that simplicity and teamwork are so important is because for every person in labor, a clinical care team is established somewhat ad hoc and may be comprised of people that have never worked together before. But at the same time, this team has to be really high performing during childbirth, which is one of the most important experiences in many people's lives. So TeamBirth was designed to be a simple way of improving care while making it easier, not harder, for clinicians to do their jobs and for patients to make choices about their own childbirth and what that experience looks like. It also turns out that when things go wrong in clinical care, the most common root causes are failures of communication. So by improving teamwork and as such, focusing on effective communication among all members of the care team, we may be able to prevent adverse events from occurring during labor and delivery. Next slide, please. You can actually keep going and then go ahead to the next slide. So specifically, TeamBirth promotes simplicity by putting methods and tools in place, which Amber is going to go over with you in a few minutes, to allow for information to be easily and reliably communicated across the full care team, including the birthing person and their family or support people. As we'll get into shortly, TeamBirth was tested in a pilot trial to ensure that its implementation wouldn't impede clinician workflow or create any barriers or other burdens that would take time away from the patient. So again, just trying to make the right thing to do, the simplest thing to do. Next slide. For teamwork, TeamBirth also enables teamwork by structuring effective communication to promote shared decision-making and create what we call psychological safety. To create psychological safety, we ensure that everyone in the room, once again, including and especially the person giving birth, feels permission and opportunity to speak and to be heard. And to echo what Dr. Gillispie-Bell said today during her talk earlier in this summit, we really need to focus on involving the patient in their care rather than just telling them what is going to happen. And so we accomplish this through teamwork and communication. Next slide, please. So TeamBirth huddles are one of the core sort of behaviors of TeamBirth implementation. And the whole actually TeamBirth care process innovation is based around these regular team huddles, which involve the full care team and give all team members the opportunity to speak and participate in shared decision-making. This is a time for the team to come together and discuss preferences, discuss the patient's expectations and plans for their labor. And these can really happen at any point during labor and throughout, but especially during shift changes or at any major decision points. Next slide, please. So these huddle conversations are structured by a simple shared visual tool, which we call the shared planning board. And this is often a dry erase board of some form that's hung on the wall, often opposite the birthing person so that they can see it while they're in bed. And it's large, it's at a minimum 2 feet by 3 feet. So again, it can be seen very clearly from the patient's bed. And it functions to ensure that the team is reliably sharing all the important information about the patient's care with everyone else in the room, and then that everyone in the room can reference this shared visual tool throughout the labor. So specifically, we have a team section where the names of all the team members are listed, including the birthing person, the nurse, physician. We have preferences to list the birthing person's preferences, just to keep those visually on the board so everybody is reminded of them throughout the labor. We have care plans separated for the mom, baby, and labor progress. And then we have this next assessment section, which can be used in different ways. A lot of people find it helpful for the physician to write the next time that they'll be coming to do a check-in. So by creating opportunities for these structured conversations to occur, and through really simple acts, such as having the names of all team members written on the board, we further create this safe space for shared decision-making and participation from all care team members. Next slide. I'm going to pass off to Amber.
Thanks, Victoria. So what Victoria just described to you were some of the core components of TeamBirth. So to be doing TeamBirth, you need to be huddling, which includes the patient in labor, and you need to be using some form of that shared labor and delivery planning board. I'm going to introduce a few additional tools to you, which we consider optional. They're really meant to support the conversation and support the birthing person's or the laboring person's involvement in the conversation, really around those key decision-making times. So go ahead and go to the next slide. Next slide, please. There you go. Okay, this is just a bigger version of that first tool, which I definitely need on my small little computer screen. So this one is really meant to foster that conversation around the time of admission. So this is best used in a triage environment or wherever you might triage somebody to see if they're in active labor. If a patient is in active labor, you're not likely going to pull this tool out. You would just take them on to their room. But it's very useful for individual patients who are not in active labor and maybe you need to go back home, or at least it's not time to admit them. If you look on the left part of this guide, there's really two different pathways for the patient. They can go home or they can stay near the hospital but not yet be admitted. And by giving them this choice, it gives them, again, to be empowered to do what they feel is right for them, their body, or is safest for themselves. And it also helps align with the care team on when is the time for the patient to actually be admitted to labor and delivery once they're in labor. Go ahead and go to the next slide. So we like to recommend that this tool be used in coordination with that admission guide. It's focused on how to, well, one, the middle column is focused on how to kind of support yourself in labor or how your partner or support people can. And the one on the right there is really focused on what you do with your care team. So if you're in that position, which happens a lot when you're triaging patients, and you need to send somebody home or maybe to walk around the hospital, that whole middle column are things that you can educate them on or talk them through that are totally safe for them to do independently. It's a good place also to point to that right column as for what may happen in labor once they're admitted to the hospital. So again, it's bridging that connection between admission, what are the evidence-based practices in medicine, and also bringing the patient into the conversation in a way that they can interact with it and can understand it. Go ahead and go to the next one. So this is a discussion aid, again, around a key decision point for delivery. And really we're looking for assisted delivery. So whether you're talking about a potential C-section or an operative birth. Now you can see down the left column, as Victoria described before, that we try to break out the way we talk about the plan of care or assessment in these three particular lanes. One around the mom, one around the baby, and one around the progress. And so you can see, as you read through what the minimum criteria for delivery is, any of the clinicians in this audience will recognize that those are ACOG guidance or other professional organizations' guidance. It's not new information, but we attempted to make the information understandable to patients and displayed in a way that really created the conversation around if it is time or recommended for an operative birth, or whether maybe there is an opportunity for more time. Again, this could be used in coordination with that labor support guide. If more time is the option, then it goes through what are some of those options that can be done to help promote labor progress. So again, these are optional components of TeamBirth. We really recommend people who are interested in using them assess what their practices, what their culture is, look at their data at their hospital to see whether these tools would be really useful in moving forward with those evidence-based practices. Go ahead and go to the next slide, please. Again, we will put our email address up at the end, but those tools are available. If people are interested in seeing them, they can always email us. So again, this is taking us back to that logic model that Avery introduced. And really the point of this is to really support that we don't believe at Ariadne or within our program that you can just hand people tools and that they'll implement them perfectly and it will go well. Any of you who have tried to implement a project within a hospital or on a unit knows that implementation is really, really crucial to the success of the project. So we took time to purposely design how TeamBirth should be implemented to ensure the most successful implementation of the program at the hospital level. Go ahead and go to the next slide. And this is the pathway that we use at Ariadne. It's not particularly unique. There's a lot of research on implementation science. So you don't have to use our pathway, but it's the one that we use, and it's, what I like about this pathway is it's circular. As many of you know who have done quality improvement, you start something and you may launch it and realize that halfway in or a few months in, you need to revisit some of the design or some of the prepare, or you have new staff and you have to kind of continue. So implementation is a continuous process. But we break it up into these four categories. First, really around preparation. Second, engaging and coaching, which a unique aspect of TeamBirth is every person that gives patient care needs to be trained. So like I think it was Victoria mentioned it before, that the teams come together uniquely every day. So to really be set up to be successful, each team member does need to go through training. The next being the implement, exciting, where we get to launch the project. And then finally the sustain phase. Go ahead and go to the next slide. This is a couple pictures from one of our pilot trials, which Neil will introduce in just a second. And really you can see on the far left, this is when we were doing some engaging and coaching with them. And you can see down on the far right for their launch day celebration. It is not required if you do TeamBirth that you buy matching pink jackets or that you even have cookies on a launch party day. But we mostly wanted to put this up here as a way to thank and celebrate all the work that our pilot facilities did in our pilot trial, which we're going to introduce some of that data to you in just a second. So go ahead and go to the next slide, and off to you, Neil.
Thank you, Amber. So I think you all have met our full team now, and we're going to keep doing this sort of round robin thing because, well, it keeps it more entertaining, and obviously, like, our whole team has put a lot of work into this, but have had to really come at this from a whole bunch of lenses. I think Victoria put into the chat that Amber is our associate director who really thinks about the implementation side, and Avery is our design lead, and Victoria is our key research analyst for this work. And we've talked a little bit through the design, we've started to talk a little bit through the implementation, and now we want to talk to you a little bit about how we've tested it, so that we have a sense that it has some basis, that it's actually working. We can go to the next slide. This was like kind of a key principle of how we chose to test this, which is really different from how things like this are often tested. We know that there are a lot of things that are proven to be effective in the context of a study, but aren't really doable by real people working in the trenches in community-based settings. And we wanted to show that this is something that could be doable. That's what we mean by feasibility, that it could be done well, that it wasn't just a matter of, checking things off on a list, but actually it was possible for people to do this meaningfully in ways that truly transform culture, and that it was acceptable, which seems like a low bar, but as you all know well, when things get changed up on us, it's not our favorite as clinicians. So trying to demonstrate that this is something that both clinicians and birthing people appreciated seemed important. So we can go to the next slide. And I guess this is really the setup for my colleagues to tell you more about the trial, but what we aim to do in testing TeamBirth was to not test it at academic medical centers, but to test it in community-based hospitals that were really different from each other in different parts of the country, so that we could get a sense of how this works in truly different contexts. So with that, I'm going to turn over to my colleagues to tell you a little bit more about how we did that.
All right, next slide, please. Great, thank you. So these are the hospitals that we tested TeamBirth at within our pilot trial. So if you look to the far right, you can see South Shore Hospital. They're located just south of Boston and South Weymouth, and they were the first hospital to implement TeamBirth. They do 3,400 deliveries a year, and they're a level 3 NICU. After implementing at South Shore, we implemented at St. Francis, and that was the hospital that had all the pink jackets. They're right in Tulsa, Oklahoma, and they do about 4,000 deliveries a year. They were our only hospital that had a level 4 NICU. And then next, we implemented at both Overlake Medical Center and Evergreen Health. These hospitals are just a few miles apart from each other and really serve kind of the same area or same population. They're both level 3 nurseries, and you can see Overlake does 3,600 deliveries a year, where Evergreen does 4,500. A unique component to Evergreen is we're the only hospital within our trial that had an LDRP model. And what that really meant for us is, instead of having around 70 nurses to train at the other hospitals, they had about 120, because they had more nurses that went back and forth between the specialties. But also uniquely at this hospital, because they had nurses working across the specialties, they implemented TeamBirth, they call it door-to-door, so that you get this transparent communication, you get to be part of the decision-making team from the moment you enter the hospital when you're being triaged, all the way till when you're discharged, and they've even begun to incorporate the pediatricians in it. So it was a really great learning opportunity for us, and we're really grateful for the opportunity to work with these sites. Next slide. Okay, this is a quick snapshot, but I'm going to talk fast because we have some data to get into, and I promised we'd have questions. So we collected data. We collected a lot of data. That's why I keep saying thank you so many times to our sites, because they were incredibly helpful in doing this for us. The first was the patient data. We surveyed patients before and during the intervention, and then we also looked at their clinical outcome data. For clinicians, if you look to the right, we also surveyed clinicians, which any of you who have done that in the past know how challenging. But we were able to get over 60% responses from our physicians, midwives, and nurses. And we did that at multiple points through the trial. And then lastly, we interviewed clinicians. We did try to target those that were maybe more resistant, or those who didn't report maybe liking TeamBirth, because we wanted to know more about why, so we could really understand what needed to be changed, adapted, or how the implementation should be differently next time. And then we really want to look at how the team interacts, which is the major premise of TeamBirth, that it's not about one individual actor, but it's how they function as a team. And you can see we had observation data, so where an individual would watch the team huddle and record what happened or didn't happen. And then we also had implementation focus groups, where we met with those who are leading the project to really understand how they were seeing it from their perspective. So next slide.
So these results come from our clinician surveys, and it's important to note that we purposely oversampled more reluctant or laggard clinicians to survey. So these really overwhelmingly positive results come from a group of clinicians that were not initially bought into TeamBirth. And just to go over this data really quickly, of those clinicians, we found that 90% would definitely or probably recommend the TeamBirth project, 94% believe the project improved care, and 88% believe the project helps clarify decision-making for non-urgent cesarean deliveries. Next slide. Our clinician interviews revealed a lot of insight into the reasons why clinicians had such positive experiences implementing TeamBirth. These are just a few of the quotes we pulled from our qualitative analysis. And I won't read through all of these. TeamBirth certainly correlates to better patient care, and it correlates to a better environment for everybody to work in. This is a quote from the OB hospitalist. And then we also pulled some themes from open-ended survey responses, which indicated that clinicians' main reasons for recommending TeamBirth included involving and empowering the patient and their family in their care, improving team communication, and creating transparency and accountability across team members when it comes to clinical decision-making. Next slide. Okay, great. So these results are from our patient surveys. Overall, patients felt that they had the role they wanted in making decisions about their labor, that their providers spoke to them about their labor in a way they could understand, and that sharing their preferences made a difference in the care they received. So these data specifically refer to that last question, and the data show that the more huddles a patient participated in, the more positive their birth experience was. So it's suggestive of a dose response effect, and this reaffirms our hypothesis that patient engagement is really key to shaping their birthing experience. Next slide. Again, just some really positive quotes from our patients. I'll let you read through these yourselves, and I'll pass the torch again. I think we can go to the next slide.
So in addition to using the pilot trial to really inform our research hypotheses, we also use that collaboration with the 4 pilot sites to inform the design of TeamBirth. We know that those 4 sites, as well as all of your hospitals, look really different and have different constraints when implementing a project. So one of our big objectives was really to identify what's the core of TeamBirth, the aspects that if you're really not doing those, we don't think you're doing TeamBirth and don't have those essential inputs to the logic model that will lead to the outcomes that we all hope to see. And what are flexible or add-on that can really be adapted to local context. So like the aids and guides that Amber showed you earlier. And this diagram below shows our sense of the core. So when we think about what's really essential to TeamBirth that needs to be implemented with fidelity across any site doing TeamBirth, it's these structured team huddles with some of the characteristics that Victoria mentioned earlier, the shared labor and delivery planning tool to really structure that conversation and document some of those key discussion points for everyone on the team to have for reference and clarity. And that implementation process that Amber talked you through to really make sure that these are being implemented with fidelity and you're supporting that change management process. However, there are lots of ways that these can be flexed and adapted to different local contexts to be able to meet the needs and practice patterns of your site. So on the next slide, you'll see a few examples of the way huddles can be adapted. I'll talk through that first one as a great example of something we learned from the pilot sites. Originally, the huddles were really designed to be happening in person optimally, where all members of the team were coming together to have these discussions at the bedside. But for many physicians who are private practice and maybe in their offices at the same time they're managing patients in labor, that was just not a feasible strategy. So our sites transitioned to having speakerphone huddles, where they would call in the provider over speakerphone and still be able to have that really rich three-way conversation at the bedside, but just with the provider joining virtually and from their office instead of in person. This actually ended up having some unintended benefits as well, where we had providers report back that they felt like they were getting fewer phone calls from nurses with clarifications, because instead of having a one-way conversation with the nurse that would then be relayed to the patient who might have questions and need follow-up, they were able to get together all as a team and build that shared mental model as a whole. The next slide shows an example of how that shared labor and delivery planning board can also be adapted. If you go to the next slide, please. And you can see this was a site who incorporated some of their branding, as well as a beautiful picture of Mount Rainier since they were in Washington, but kept the essence of that simplicity. So the goal is to make sure the board is still a simple shared tool that has information that's accessible and relevant to all team members. But other aspects of the design can really be adapted to meet local site needs and really promote that buy-in when it really feels like it's owned by and reflective of their unit.
All right, thanks, Avery. So kind of to start wrapping it up, we're now at the end of the logic model, and you can really see, sorry, I've got a little alarm on my computer, that we're aiming to change safety and dignity. You can see that bottom arrow from dignity that points back up to safety. And it's because that we do believe by focusing our efforts on the patient's experience, on what you guys have been talking about all day today with respectful maternal care, that it actually is going to point towards improved outcomes as well. So go ahead and the next slide, please. And next slide. So for future work for TeamBirth, the first being generate data and evidence. So we described to you our pilot trial. Hopefully our manuscript will be out in a few months and you'll be able to read the details of that. But one of the opportunities we have going forward is really to test in a more varied context. We were setting out to see if people could do it and they liked it and to make sure it was safe. We feel confident in that now, and we need to test in areas that have more vulnerable populations and just a greater diverse patient population. The second one is adapting the solution. Well, we know a lot about the solution from the community hospitals we worked in, and you saw they were all around 35 to 4,500 deliveries annually. We still have opportunities to learn what TeamBirth is exactly like in a more rural context, or maybe a small critical access hospital, as well as maybe in an academic center where you have varying levels of people who would be involved in those huddles. So again, that'll be future work for us right now and in 2021. These last 2 points around building a scaling infrastructure and cultivating partners and networks. We aim to make TeamBirth the standard of care all across the United States, of a new way of patients, it being normalized, that patients be a part of the conversations, not that the conversations take place in the hallway, but that every laboring person is actually able to have all that transparent information that the rest of the team has. In order to do that, we do need to partner. There's no way that the 4 of us could go all around and spread this across the globe. And so we continue to partner, just like Neil demonstrated in that slide from 2017, with groups like yourselves, with leaders, professional organizations. And so we look forward to being able to continue the conversation with you guys. Go ahead and go to the next slide. There you go. And actually, let's go ahead and skip this one, Shannon. Thank you. I only have a few minutes for questions and answers if anyone has one. Okay. Oh wait, go back one more to the designers, because I want to acknowledge my previous role was working for a quality collaborative out in Washington State, and I know that all of you that are here, you're giving up your time. You may have other responsibilities and other roles, and you're here because you really care about the quality of healthcare in Virginia. You guys are advocates, you're leaders, you're professionals. You may be parents today too. You might be homeschooling your children while we're all working in varied contexts. But I want to add one more title to you, which is a designer. So per this definition, anyone who devises courses of action aimed at changing existing situations into preferred ones is a designer. And I welcome you to think of yourself a designer, think of what we presented today, and we'd love to have your feedback. I guess our email address isn't on this slide. I thought it was. My apologies. You can email us at deliverydecisions@ariadnelabs.org. You don't have to be able to pronounce it. You just have to be able to spell it. Maybe one of my colleagues can put it in the chat box. But we welcome your feedback. And if there's anything else we can answer now. Shannon, do you monitor the raised hands or maybe the chat box?
Yeah, I will go ahead and look at some of the chats. I'm going to take this, stop sharing so we can see. So we do have some questions coming in already. And the first one, and I don't know if you can see it as well, but Kristen says, I can't help but believe that most of these communication devices should actually be introduced to the pregnant person and their attendants during the prenatal care period. Often when people come to L&D, they're not in a great position to introduce a novel way of communicating. All of these communication devices would be so great to center discussions around with pregnant persons and providing clinic, huge dialogue starters for sure. So has that been part of the implementation, or have you worked on it, or are we just starting first in the hospital? I think that was a lot.
No, that's okay. Kristen, it's a really, really good question. And we do feel like it's a really important part of sustainability for TeamBirth. We purposely start in the hospital on the unit because that's where the intervention takes place. But we do coach our teams to start there, train everybody, and then go back upwards into the clinics. You go into childbirth education, wherever your patient population is congregating, to get them exposure to the tools so they're familiar and more approachable, and that they get to practice with them. So 2 of our sites introduced this into childbirth education, which is varying degrees of use across our country, but and they had every one of those patients fill out a whiteboard ahead of time, so they knew how to interact with the materials. So it's definitely something that we coach and is prioritized, but we do start at the hospital level where the intervention is. I actually see another question from Donald Dudley around that. We're really wanting to know how we have thought about TeamBirth in the context of COVID and the restrictions around being together as a team. It's a really, really good question. We've talked to our teams recently about this that are still sustaining using TeamBirth, and they actually said being so comfortable on speakerphone really set them up to be successful for dealing with COVID positive or suspected patients in labor, because it's been normalized that maybe not everybody has to be at the bedside to have a plan or an assessment, but that can be done maybe more safely at distance using like a telehealth screen or just being on speakerphone. So that's one way that we've thought about how you can still bring people together without actually being physically together. And great point about including pediatrics. We don't limit it to neonatology. It's anybody who's going to be in conversation around the plan of care that we recommend be involved in the huddle and have some sort of exposure to the project. So when they find themselves in a huddle, they know kind of what their role is and what to expect. Let me scroll. Thank you, Avery, for putting in the email. Somebody comments that it's challenging to get all the disciplines together at the same time due to the moving parts of the labor floor. It's very, very true. We don't necessarily enforce that everybody be trained at the same time. You know what's best for your facilities and how you've accomplished training in the past. But we have found it's really good to let people practice as multidisciplinary groups so that they're less overwhelmed or more comfortable at what it looks like to communicate the plan with the patient being a participant.
If I could just add to that also, Amber, you said something the other day that really struck me, which is at one of our pilot sites, someone commented that you're not really changing a lot of what you're doing. You're just taking all of those conversations that normally happen in the hallway between the clinicians, the nurses, and the doctor, and just bringing them to the bedside. So actually what we found in our qualitative analysis was a lot of people saying that TeamBirth actually saved them time in the long run because they were getting less calls from the nurses to clarify questions from the patient or when the doctor was going to come back for the next visit. It was just all figured out right there at the bedside or on speakerphone at the bedside.
Yeah, there's a few, thank you for adding that, Victoria, I appreciate that. There's a few questions about the EMR assistance. So we come from Ariadne, which is all about simple tools that anybody can use across the globe. So we did not immediately go towards a tech solution because it's not in our organizational DNA. However, there is an opportunity for us to figure out exactly how this could be captured and directly gone into the EMR. So maybe if we figure that out next year, then we can actually think about retiring, but we haven't yet. So what we're doing right now is we're encouraging people to either document in a progress note that they had a huddle, this is what was covered and who was present, or several of our teams have actually built it into an EMR field where they're clicking that, the options of who was present, what was covered, so that it can be acknowledged. But ideally, what's written on this board could be like captured in like a smart board and sent directly into the record. But we don't have that expertise on our team yet, maybe 2021. I think we're at time, Shannon, unless there's any other questions.
Yeah, I first of all want to say thank you very much, ladies. Oh, it looks like we're just, and it seems like this is a reoccurring question, and I want to kind of, because we had this conversation a week or two ago with our OB hemorrhage. We were talking about team briefs after an incident. And that part of the OB hemorrhage is to actually have the protocols and to require huddles after a sentinel event. And so it was very interesting to look at where hospitals across Virginia are. Some have it in their protocol that it's required, but it's required in the protocol, and that's where it stops because it's not being enforced. Mm-hmm. There's, you know, the one physician covering 10 patients. So there's always excuses. But one hospital, Donna, if you're on, please jump on, but out in Centera, and she said it was definitely a change in culture. So we've heard this now twice today, a change in culture. We can keep doing what we want to do, and we're never going to change. Or we can change that culture, and we can start to find opportunities and ways that we can put this into our workflow. It's not going to be easy. There's going to be resistance when we first start something new, but I do think, and you guys have demonstrated with 4 other hospitals, that this is possible, and it's more or less looking at how we can turn this on its head and start small and then, you know, work out the kinks. And as you showed with the diagram, the circular, we might start and then we come back with barriers and then we go back forward again. So I do want to say thank you very much, ladies, and Neil. You guys were fantastic. And for those of you, we are continuing this conversation with Ariadne Labs. We know this is just the beginning and the introduction, and so we hope to bring you all back kind of as a phase 2. We'll talk about that after the summit. I know Victoria's shaking her head. We've had a little bit of these conversations. So, but yes, thank you very much, ladies.
Great, thank you. Please email us if there's any more of the questions that you want us to answer. We're happy to do that at another date. And thank you guys for having us. It's really an honor.
Thank
Bye-bye.
you. Oh, there you are, Donna. Donna, do you want to jump on and kind of, are you muted? I think you're muted, Donna. Let me unmute you. Hang on, I'm trying to find you. Can you unmute, Donna? There you go.
I think I unmuted myself.
There you go.
Did I do it?
Yep, you did.
Tech and I are not the best of friends. The culture changes that we all look towards doing just take incredible persistence and time. And the persistence isn't in, hi, we're going to do this in the next month. It's the baby steps that lead into the culture change. You know, from looking at the whys of why you come into work every day and what we do as a team, to now how do we build on that and make this the experience our patients truly deserve. It takes time and it takes effort, and it's frustrating, and you take 2 steps back and you take a half a step forward, but the satisfaction of watching the way we've always done it move into this is how we function, or this is how we do it now, is incredibly gratifying, and really at the end of the day, the patients benefit.
Absolutely. So thank you, Donna, for adding that. All righty. I know it is 4:18. We are going to chug along. If you need to stand up, please stand up. If you need to run to the bathroom, please run to the bathroom. We did not build a break-in here, but I am going to turn it over to our OB co-chair, Dr. Donald Dudley, and he is going to facilitate this next portion and final portion of the summit. So.
Well, hello, everybody. My name's Donald Dudley. I'm the obstetrics co-chair for the VNPC. And, you know, as we all do, we wear many hats. I'm also the MFM division director here at University of Virginia, hence the little name tag there. And I think for the breakout session here, we're not really breaking out. We're just going to have a discussion. And so I think what we're going to try to do, Shannon, how do you want to play this out as far as unmuting and muting people?
I am going to try to unmute. Well, if everybody can try and unmute themselves, well, yeah, let's unmute, and then if you don't want to talk, then go ahead, you can remute, but I can only mute all, so I can ask everybody to unmute.
Or 2 weeks old, I guess.
Unmute,
Okay.
mute, everybody mute, please. There's a lot of background noise. We were afraid that would happen. We might have to stop. There are going to be people who are off the system. Let's see, most people are still muted. Kate Minnick, Lindsay Martinez, I'm calling you out. Mute yourself. You must not be there.
I'm like, no, he didn't. He didn't save your life. She's like, I could have a colostomy bag. I'm like, and if he had waited 2 weeks, like, I definitely.
We might have to go to mute all again, Shannon.
Okay.
Neither of my two sisters.
I'm hearing a very animated discussion.
You're muted now, Donald. So now everybody, you need to unmute if you want to talk. That's what we were trying to afford everybody, the opportunity to be able to talk. So you will now have to unmute yourself. And Donald, you're muted. Oh, allow. There we go. Now can you do it?
Yeah, hi.
Okay.
I'm back now. So anyway, I don't know what you did, but it worked.
I don't know.
We're all still learning the world of Zoom. So anyway, for this last session, it's just going to be a discussion. And I think what we can do is let folks just answer in the chat box, or just a few questions that we can talk about, and as we get towards the end. And if nobody wants to contribute much, we can all finish up a little early and go home. And so the first question I think we need to ask, and first a little background about why we chose respectful care. In one of my other roles, I'm one of the scientific editors for a obstetrics journal, and we're seeing more and more papers, especially coming out of low and middle income countries, talking about respectful maternal care and how this is a problem in these lower and middle income countries. But it's also, I'm seeing it more and more in high income countries like our own. And it always struck me as being, I mean, isn't this self-evident? But obviously it's not, because this is a huge problem. And so, you know, how do we go about engaging providers and educating people about what it means to be respectful? And that's why we came up with this theme for the discussion this afternoon. And so I think the first question that we'd like to ask, and you can put into the chat box, and if you want to speak, maybe Shannon, you can raise your hand and Shannon can let you talk, and maybe I'll call you out too, is what's one thing that you learned today that you did not know beforehand that was an aha moment that you said, aha, that's something new, and I hadn't thought about that before? So if you could just put that in the chat box now, that would be great. And don't be shy.
And real quick, this is Shannon. I just wanted to kind of circle back, kind of full story on, we really do read the evaluations and we really do take it to heart what's been said. And so we kind of designed this summit this year about, we wanted to identify the topic. We wanted to present the data at the local level. We wanted to highlight what is being done at the local level. We wanted to afford everybody the opportunity to learn how to implement, because the so what is what has been coming up after we present this with the summit. And then this is kind of the culmination of what we would have been able to do in breakouts and have that further discussion on what you're going to take back. So just to kind of bring this full circle.
So we're getting some comments now. Respectful care model contract for employees. That was kind of novel to me too. I hadn't thought about doing that. And what that means, how do you define that, I think is going to be an important issue. The fact that folks are working on this, you know, Norfolk is working with CHIP to follow up on how you go about doing this. Let's see. Kirsten talks about the tools looking at mistreatment in mothers on Respect Index. She's very proactive. I like that. Way to go, Kirsten. Caitlin talks about Amber Price, who presented on respectful maternal care and obstetric violence. I also thought Dr. Gillispie-Bell was awesome. It was a great talk. You know, creating a respectful atmosphere among the professional peer group, I think, is also important. That's certainly what we've been doing here at UVA. We've been having team-based huddles now for a couple of years, but it was we never really included the patients, like in the TeamBirth model put out by Ariadne. Examples of microaggressions. You know, I thought that was it's a great point, Katie. I thought that Dr. Gillispie had a lot of great practical examples that about how very often simple things that we do are actually microaggressions. It's something that was also I've been learning more and more about. The fear that African American women can have when being hospitalized and not being heard. I think that really requires developing a very respectful patient interaction, I think. And yeah, the privilege should not be the gateway to professional care is like, that's definitely true. You know, I think, you know, Kelly talks about moving from volume-based care to value-based care. I think that's happening regardless of what we do. And certainly it is the key to doing this, but, you know, the value-based care is coming whether we want it or not. And so it's going to be very important, I think, when we go from this. Okay. Looks like that's about all we've got on this topic. So another question now is, what are you going to try to implement in your local site? Are you going to do something with this information that you've learned today? I mean, other than just say, oh, well, that was really interesting. That was great. And then you come to work tomorrow and it's all the same. So what are you going to try to do? One thing that you're going to try to do at your site, if you can expand upon that. Anybody have any ideas about what they're going to be doing? Just fill in the chat box. Anybody want to offer what they're going to be doing? Maybe raise your hand. You can kind of, or just say right in the chat box, I want to offer something. Rachel, you want to expand upon that? What you're going to do? Rachel Freed, can we let Rachel talk?
Dr. Dudley, can you guys hear me?
Yeah, go ahead, Rachel.
So I didn't get to see everybody's discussions today. I only got to see the second half of the webinar, but Megan's discussion around Norfolk really spoke to me. I have a couple of community-focused grants that have come across my email inbox And I'm going to reach out to her to see if those grants can be useful. I've already done something similar with the Partnering for a Healthy Virginia initiative. So anywhere that the HIE can partner with existing partnerships, like I've done with VNPC and Shannon and you, I would like to do that. You know, the most we can use our existing infrastructure, things that are already there, and not duplicate our efforts. Super important.
Okay, thanks. Felicia, can we let Felicia Tyree talk? Felicia works at our place and she's the head nurse on labor and delivery. Are you there, Felicia?
Hi, Donald, I am.
Oh, hi. So what did you think about the whole whiteboard thing? I mean, I was trying to figure out how can we do this because we don't really have a video connection that our system feels comfortable with from a HIPAA place. How do we make this work? What do you think?
Right. The whiteboards that we currently have are not particularly L&D specific. I really liked just how streamlined the whiteboard that was presented was. I'd also like maybe something electronic pulling forward.
Well, yeah, I was kind of envisioning an iPad on a stick, you know, going from room to room to room that everybody was talking in on. But again, it's going to have to be secure somehow, and I don't know what the right model for that is.
I don't either. We're going to have to we'll look into it together, Donald.
Yeah, they have to be a DoxyMe thing at least here until we get something else figured out. All right. Kirsten, you've been extremely active, so why don't you tell us what you're planning to do?
So tomorrow, like I said in the chat, I have a meeting with some of our upper leadership, and I've been working on this idea that that the group prenatal care program is actually an anti-racist tool. So looking for ways that we can, outside of just hosting an implicit bias training, like a one-off kind of thing, or having a signed statement from everybody in the department that says, yeah, we sure do love people, you know, but some like actual deliberate actions that we can take that we can show and say, here's what we're doing. It is an anti-racist tool. How do we know? Because we take literature from anthropologists and sociology, and education especially is doing a lot of work around anti-racism curriculums and putting them into place. We don't really have a lot of that in healthcare, so that's something that I'm very interested in. So that's what I'm working on.
Yeah. And Kirsten, where are you from? I can't remember.
I'm at Virginia Commonwealth University.
Okay, awesome, great.
Yeah.
Tell Ron I said hello sometime.
I will.
Okay, I appreciate that. Dina Carey, you asked about the Angel Eye cameras. Are you there? Are you guys using that?
We are not using it. We are looking into it currently. I think Jonathan, do you guys have it at UVA?
I really honestly don't.
We do.
Oh, okay.
In the NICU, we do.
Yeah.
Yeah,
So I know it's not two-way interaction and that the family's from home, but at least they would be able to hear what's going on, correct?
They cannot hear. They can speak to the infant, but they cannot hear anything in the NICU.
Yeah, and my bigger concern would be, is it HIPAA compliant? And is it something that, you know, is I mean, that's always an issue around here.
Yeah, for our COVID patients, we've been using the hospital secure WebEx to connect families during care times, and again,
well, that may be the way we could do it. Yeah.
Similar thing. We had iPads that were designated for the COVID patient rooms, and we put the iPad in there and then kind of prop it up, and then that we would include them in, you know, from home or from wherever to be part of the care plan and that conversation. Just an idea.
Okay, awesome. And Laverne, you talk about the, Laverne Lee, are you there? Are you still there, Laverne?
Hello?
Talk about, yeah, hi, you talk about taking the implicit bias test yourself.
I do. I plan to take it myself. I try my best to be, kind to all my patients. I always try to provide holistic care, but of course we may have biases that we're just not aware of. So I service individuals that are pregnant women, postpartum, and infants. So, and teen moms. So I plan to take the test in the hopes that I'll be able to see my own biases to better service the people that I do care for.
Yeah. One of my biggest concerns about implicit bias training, because we've done it here, is that it becomes a check the box experience. People spend an hour or two doing their implicit bias training, say, okay, I'm good, I'm done that, check that box off. And it doesn't really do anything or change anything. And so how do you make implicit bias training and teaching something that is relevant and changes behavior? Mike Moxley, are you on the line still? I'm going to call you out, sir, because I know you and you're such a good guy.
Yes, can you hear me?
Yes, we can, Mike. So do you have any ideas about this?
Yes, quite a few. I was actually going to type in, so thank you for letting me just speak. Yeah, like you said, I think the issue is with the, you can take the implicit bias test, but given everything that's gone on recently, we really need to take it up to another level. And that's where, it's one thing to not be racist, but it's another thing entirely to be anti-racist. And everybody on our admissions committee at Georgetown now, and a lot of the staff and faculty actually take anti-racism training that's set up by University of Texas, El Paso. And it is a wonderful thing to do. So in addition to taking those implicit bias trainings that come, you really need to do the anti-racism training. It is definitely eye-opening. It's about 6 hours total of time, but it is time well spent, and I think everyone would get something out of it.
And is that something that you have to pay for, sign up for? Is it offered free off the UTEP website? Is it coached? I mean, how does that work?
Well, I didn't have to pay for it, but I can send you the link.
That'd be great. And maybe
yeah.
we could investigate it and see if that's something we can put out to the group, because that would be awesome. I think that's a really good point. And it's one thing to be taught implicit bias, but it's another thing to become an anti-racist. And that's one step beyond, I guess, implicit bias.
Right.
So
right.
Great. All right, thanks. Let's see. So Leslie talks about doing it on an annual basis. It is, it's, I don't know about everybody on the call, but I only have about 5 things on my checklist of required certification credentials, things I have to do that I haven't gotten to. And it's just one of these things that you just hurry through just to get it done and get it out of your hair. And especially because I have privileges in several different hospital systems right now. And so it's, throwing something else on top of it becomes, it's just such another thing to do. But I think this has got to be one of these things that has got to be considered really important. And whether or not this is something that can become a statewide mandate for healthcare providers, not just doctors, but nurses, midwives, doulas, everybody, because racism can go both ways. It goes all sorts of different ways. It's not just one race on another. It can go all sorts of different ways. And I think it's valuable for everyone to learn that. Mike, did you want to add something to that? I mean, you came back on.
No, sorry, it's just technical.
Yeah. No. If that's the only technical thing that happens to you today, it's been a good day, sir. Jay Noons 24, I think it's important for hospital systems to strengthen their community partnerships to truly have value-based care. Jacqueline, you're out there. So Jackie, how do you want that to work?
Is that the one?
No, Jacqueline Nunciato. Jacqueline Nunciato. And you can speak also too, Jackie.
Can you hear me now?
Yes.
Can you hear me?
Yes, we can.
Okay. I wrote the comment about programs that talk about the Black disparities in the community and working with the patients and the community. But on the teams, I don't see representation for that. And it just is a flag for me to say, how do you manage something that you don't have someone that would help you with that being on the team?
Couldn't agree with you more.
Well, I appreciate you agreeing. I thought that's something we might want to address or have some, can't tell the teams who to have. I'm sure specialties and people that are engaged and involved with that, but it's some outreach should happen to it be inclusive.
Absolutely. Jacqueline Nunciato, did you want to talk about value-based care? Are you out there still, Jackie?
Yes, I'm here. Hi, how are you?
There you are. Hi, how are you doing?
Good. Sorry, I'm on call tonight, so I'm just pumping before call. So I wasn't.
That's maybe too much information.
I know. I think you can hear it. So sorry.
Yeah, as hearing you is fine. You don't have to show yourself.
Okay. Well, I think it's been brought up during the conversation, but I think and Donald, you know that, but I have a nonprofit in the area for maternal health, for advocating for maternal health. And one of the reasons I started it specifically in this area, Southwest Virginia, is because I felt like I didn't feel like there were gaps as much in resources in the area, but there were definitely connective gaps, meaning I didn't feel patients really knew about the community resources that were available, because I really feel, and I'm sure everybody can kind of attest to that, as an obstetrician, you can't be everything to everyone, but there are so many needs to fill. And I think part of our job in those, 14 visits that we have usually for patients is to be able to take that time that you can spend and try and plug them into the system a lot better than we're doing. And I think, we talked about that with mental health, but that's a perfect example. You already know patients that are coming in with high risk for, mental health issues during the pregnancy, and you see them for 10 months. And then at the postpartum visit, you're trying to scramble to figure out, okay, you've diagnosed them with postpartum depression, where should they go? So I think it's really, if you can lay that groundwork ahead of time, I think it's much easier to take value in the actual, the visits that you have, the time that you have.
Yeah, I think it's not just patients not being aware of community resources. I think doctors and nurses are not aware of it either. I mean, I know that's one thing that we always struggle with, is what's available out there for the patients.
Yeah, I mean, I think, having the nonprofit, I've said this a number of times during interviews, but having the nonprofit has actually made me such a better provider, because I've gotten to know the community so much better, and it's really opened my eyes. I mean, we work very closely with CHIP, Healthy Families, a bunch of the lactation specialists in the area. Even in our own institution, it's made me more aware of some of the great programs that we have for infant grief and loss, for, a NICU mentorship and support team. I mean, I didn't know that any of this stuff existed within my own institution. And so I really think there needs to be a more interdisciplinary approach to, okay, this is what my department has to offer, and this is how we can kind of come together and make a difference.
Okay, thanks. And Jareen, good point. I stand corrected. Nursing is certainly very normal, and what half of us are not equipped to do. So I appreciate that. Kelly, did you want to talk about local home visiting programs?
There we go. Can you hear me now?
Yes.
Yes. Well, it's very exciting then that you did know and do know about local home visiting programs in your area, because that's where we can be the resource for you doctors and nurses. You guys are doing the medical side of it, and we very much can do the community, side of that and linkage to services in the community. I know for our program, we're out of the Chesapeake Health Department, and we're an RN-based home visitors, and so we can provide a lot of services to families in need during the prenatal period all the way up till when the baby is 2. So that's really one of our biggest roles, is linkage to services in the community. So we would love to partner with all of you, because we would love for women and families to have home visiting prenatally. We tend to get a bunch of them after they've had the baby, but prenatally would be really ideal, especially, with all of the different issues that and challenges and barriers that our families face. So
yeah.
Thank you.
Well, and I think you bring up a really important point, especially about postpartum care. I've become increasingly, what's the word I want to say, disillusioned with the way we deliver postpartum care in the United States. It's old-fashioned, outdated, and outmoded, and we need to completely rethink the way we do postpartum care. So it's away from a medical model, and it's more to a social model. Just, seeing the obstetrician 6 weeks after the baby's born, I don't know what's going on with the baby. I mean, I don't know what's going on with her social life. I just make sure, oh, well, let's talk about, birth spacing and that kind of business. And that's it. I mean, then they're gone. I mean, it just doesn't work. And I know back in the days when I used to have a private practice, I would always see, ever since the mid 90s, I would see all my patients at 2 weeks postpartum, and then at 6 weeks postpartum. Because I was always taught, if you're going to have a complication postpartum, it's going to be in the first couple of weeks. And so, well, why are we waiting 6 weeks to see the patient? That doesn't make any sense. But it's just the isolation of the obstetric care provider in that context, I think, doesn't work. And so I've had this vision of delivering postpartum care, and I think you bring up a really good point about home visits, is that there's a one-stop shop that you see the pediatrician, an obstetric care provider, a social worker, a mental health professional if you need that, all in one place, and you just come and see folks that you need. And I think having the idea of having a home nursing program, that they would be there and say, well, let's set up a home visit so we can come out and see how you're doing, and providing that continuous care that needs to occur postpartum, aside from just one visit.
I would agree with that. I think our women and families deserve better than what they're getting right now. It isn't just you birth the baby and we're done. It's really a continuum for our moms and babies, and that's really what we want to provide, and really partner with the providers. You guys can only do so much and we can only do so much, but when we work together, we can really make a difference for the moms and babies in our area. And I'm super excited to hear about Megan partnering with Chip and everything. And I'm hoping that that's just from there, in our area, we can really just kind of grow that kind of model. It would be great.
Great, thanks. Megan, did you want to say something? You sent me a chat to make
Yeah, I just wanted to mention, back in, 20, 30 years ago, our patients had their moms and their families and everybody else that came around them in the community to help take care of them. And in this day and age, in this generation, everybody kind of lives on their own in their own little bubble. And it's just a different world that we live in. Neighbors don't talk to neighbors anymore. And so everybody kind of lives in their own space. And it's something that we can't do things the way they've always been done anymore. So we need to look at it from a different place. We need to look at it from a different perspective than just sending a patient home and thinking that, oh, their mom will take care of it, or their neighbor will take care of it because they had a support system. And now that just doesn't exist in the world that we live in. And so we need the doulas, we need the home visiting programs to support these families because they're floundering and they really don't know what to do with this baby, with this life that they've been handed, with the comorbidities that they have. And, you know, so we've got to do what we can do to really decrease these disparities and help them.
Yeah, well, you know, it takes a village, but the village has kind of fallen apart a little bit, partly due to, I think, social media and people being so absorbed in their own cell phone, but also now with COVID restrictions, it's just so blooming difficult to actually be in the presence of other. I mean, even now when I go out, if I'm around someone that doesn't have a mask, I get very uncomfortable. And so it's a difficult time. That's why doing these kinds of programs, I think, have a potential really big benefit. Let's see. Yeah, I think the idea, Lisa brings up the idea of community doulas, and Shereen talks about Cuba. Cuba puts us to shame in so many different areas, including postpartum, I think, and infant mortality rates. And those are great comments everybody has. Okay, and then Jackie brings up birth trauma educators, and birth trauma is another issue that maybe we could talk about sometime in a future meeting, and that is, you know, the fact that women often end up having some sort of post-traumatic stress after having a traumatic birthing experience, as well as healthcare providers for that matter as well. So. Well, I tell you what, it's 4:50. I think we're probably beginning to wrap up a little bit, and we've managed to keep 136 people on the line this late. Maybe we should wrap things up. Joe, did you want to provide some concluding comments?
Sure, thanks, Donald. So I just want to thank everybody for being here with us today. It was a very interesting afternoon. We heard from great speakers, and thank you for your patience with us navigating through Zoom. Again, it was our first experience with this, so I think it went well. We just talked about very important stuff today about respectful care, which is a universal human right due to every childbearing woman and their newborn in every healthcare system. So the experience women get can empower and comfort them, or it can inflict lasting trauma and damage on them. So memories of childbearing experiences stay with women throughout their lifetime. And we, again, have to think about patients, not just medically, but emotionally as well as psychologically. Today we heard great presentations about the importance of physician-patient relationships, how they affect patient care, the effect of the significance of maternal respectful care, and the impact on the maternal baby dyad. I just want to thank everyone for attending the summit today and participating in our breakout session. Please make sure you complete the evaluation that you receive. As Shannon mentioned, we value the feedback you guys give us, as we always strive to improve our summits every year. Hopefully next year we will be able to hold it in person. We'll be looking forward to doing that, as in-person meetings cannot be overstated. As Shannon, you want to talk about recording and being able to, and the CMEs and CEUs again?
Yeah, thanks again, everybody. I couldn't have done it without everybody here. We're one big team. Not just one person did all of this. So thank you very, very much again to all of our wonderful presenters today. Megan, dynamic. Dr. Gillispie-Bell, dynamic. and Ariadne Labs. So I greatly appreciate you all. You really made the summit today. So real quick, I will be sending an evaluation later this week by email. Please respond to that. If you've requested CEUs or CMEs, that is how you're going to be timed. That's your evaluation at the end. Also, for any of you, one more time, if you did social distancing in person on one Zoom account and 5 of you were in the room, I need to make sure everybody's name and organization is in the chat. So if you hadn't done that already, or you can just email it to me, that's fine too. So other than that, please fill out the evaluation. We really do read them. We really do listen to them. We really do apply what you guys put. Nobody better complain about parking this time, and no hot or cold temperatures. That was me all this year, so don't say anything about that. Otherwise, I don't have anything else, so I want to thank Dr. Donald Dudley for being our co-chair, Joe, co-chair. We did not introduce ourselves in the beginning, and I apologize for that. I want to give a shout out to Jen McDonald from Virginia Department of Health, who's on the steering committee, Lauren Winston, who was a huge help, that is steering the Maternal Health Collaborative with VHHA. She is on the steering committee, and also to Christy Burnett, who's on the steering committee as our VHHA representative. So all of us are one big team. We couldn't do this without each other. And then again, thank you to all the executive committee members, and that is all I have. So thank you guys. Have a great afternoon.
Bye, everyone.